Hi, I'm Shelley Fold-Nasso, CEO of the National Coalition for Cancer Survivorship. I'm pleased to have Dr. Kashyap Patel joining me today. He's a practicing oncologist and CEO of Carolina Blood and Cancer Care Associates in South Carolina and a national leader in community oncology, serving in leadership roles of the Community Oncology Alliance and Association for Community Cancer Centers. His book, Between Life and Death, From Despair to Hope, was released this summer. In it, he asked the question, how do we prepare our patients for a good death? He shares the experience of some of his patients and his own experience along with spirituality, philosophy, and science. So Dr. Patel, thank you so much for joining me today. And tell us, to start off, what made you decide to write this book?
Well, that's a very interesting question, Shelley. First of all, thank you for getting me on this kind of discussion, because it's something that we look at as a stigmatized discussion in society. And having lived in 3 different continents, multiple different cities, and different areas of practice as an oncologist for almost like 30 years, I felt that I never was prepared to handle the moment when I had to start discussing goodbye with my patients. No medical school has ever taught any students how to deal with that topic. And frequently, more often than not, what I realized was by denying that discussion, we actually would deny the family of the patient and caregivers a chance to put a full closure. So I started learning about the process of death and dying. I went back to the days of Egyptian and how, that civilization particularly dealt with the idea of death and dying, building pyramids and bodies. I learned about, the entire shifting paradigm and definition of death. I learned about how Judaism, Christianity, Hinduism, Buddhism, and Islam dealt with death. And then I started kind of literally discussing with my patients about their own perception of when the journey to cancer coming to a level where we know that the medicine is not going to work anymore. How do we stop treatment? How do we start discussion? And I felt that there was a need, there's a knowledge gap in understanding how to bring up the conversation. But it's something that we all have to deal with it. Death is not an option. It's continuation of the journey beyond the physical mortal remains. So I decided to write the book. And I came through a perfect person who actually kind of inspired me to compile the experiences and share these stories in this book.
So great. So you started with the story of Harry Falls, your friend's husband. So why don't you tell us about him and his journey and how he inspired you? Because it seems you carry his story throughout the book.
Yeah, so Harry Falls was the main character in the book. He was a real patient, except a different name, and he was a Britisher. So it's a different concept of life and death compared to America. The hospice movement started in England, so they have a different ideas about what to do when you reach a point in life. So when Harry was diagnosed with terminal cancer, his wife was a director of the cancer center at the place where I worked. And Harry was very clear. He said, Doc, I've lived a full 78 years of life. I've lived to the fullest. And I would not like to lie down in these tubes and chains in a hospital. But I want to understand what happens when people die. How do you kind of prepare for the death? His biggest concern was his family was all over the world. I think he married 3 times. Some of his children were in Australia. So he really wanted to be able to put a full closure and full circle on his life. So we started discussing about whatever I knew about death. And then finally he says, have you seen death? Have you physically been present when somebody leaves the body? And I say, yeah, I do make conversations. I go to my patients' home when they're ready to leave the world. So I'll be more than happy to share with you what my own experience is. So we both decide to sit down under a healing dome. My small clinic in Grove, South Carolina, a beautiful tropical land, a beautiful healing garden, healing dome. And we decided to meet once a week, and I started sharing stories of multiple different patients one at a time, from 29-year-old young, very aspiring girl who wanted to be an actress and theater artist to someone who was 45-year-old, very successful attorney. And so we decided to share our own journey together, and that's how the idea of the book came together.
So That's inspiring that he helped you kind of give you the framework to write this book. And so you talked about the fact that the experience of dying is highly individualized, and the idea of a good death is not the same for everyone. And it's also, you said it wasn't a random event or a matter of luck. So how do you help patients understand what a good death means to them and then to plan for that good death?
Well, that's a very, very interesting conversation I have had multiple times on different occasions with different patients. A good death is something that does not leave behind a sense of stigma and sense of remorse on the part of patient as well as patient's family. What we forget here, Shelley, in the modern quest of eternity of life is that, first of all, we are not treating a piece of meat. We are treating a human being with aspirations, expectations, and family. And we have to individualize each patient's experience in a unique way. And a good death again is something that is graceful, that's acceptable, that patients and family members can actually remember that in more or less celebratory fashion, not in the remorse and regret, kind of having regrets for not having done everything. In my experience, the opinion, virtually every patient should have an option of dying at home in their own bed. We prepare and spend so much money in the society for baby showers. We do birthday parties, we do holiday parties, we do send off parties, but we never think about death and we never plan for death. The only thing that's certain after we honest a human being is that we are going to leave this world one day. And somehow or the other, we've stigmatized death so much that we've created a sense of a winner and loser. Going back to days of President Nixon when he decided to declare war against cancer, we created that in war you have heroes, you have the people who are green berets, you lose and you win. And so any discussion about death become a discussion of losers. And then the more aggressive we became on our pursuit of eternity and living for foreseeable time, the more likely it was that the physician who was a champion and was leading the team as a coach started feeling uncomfortable about to bring up the discussion of death. And then so many direct-to-consumer ads on television make patients feel that we have option to treat people, and so nobody should be dying on this planet. So we started developing a concept in America, particularly, that death is more of an option and it's not a part of continuation of the how we are, who we are. And so we started developing unusual expectation of eternal living. And that's what actually led to the concept of doing everything, pushing people to the edge point that when patients die in a hospital, studies have shown that the caregivers are left behind with terrible psychiatric issues. And I'm talking about the structured prospective studies published in standard journal like Journal of Clinical Oncology shown that when patients die in a hospital in an unexpected setting, the caregivers are left behind with lifelong remorse and lifelong psychiatric issues. So a good death, coming back to your point, is dying in your own hospital bed, in your own home bed, not hospital bed, surrounded by a loved one, listening to spiritual serenity music that you lived with, and just that's how it should be. Bringing personal story, my dad was 84 years old, and about 3 years back, he developed pulmonary fibrosis. He used to live with my nephew in India, and I decided to fly there every 3 months for a week at a time. And every time I would remind him that if I don't see you again, please move on. Please don't wait for me. And my instruction to my mom and to my dad was, don't call 911. I know dad is ready. And one day in January 2019, at 4 p.m., he called my nephew and said, "Oh, it's been wonderful pleasure raising you up as a kid. And your uncle who lives in America has made me very proud. And I'm going to sleep." And he went to sleep. Literally, he didn't wake up after 2 hours. So that should be the ideal death. And I live by example, actually. I live an example. I always walk the talk, and I personally feel that if I had to choose death, I would want to be in my own bed.
Thank you for sharing that story. I mean, it's I think that we have really good hospice care in this country that can help people have a good death and help plan for that and have the services and support they need. But we still have a lot of fear about talking about hospice and feeling like that's giving up. To your point about talking about the battle metaphors, and then I think also then sometimes patients feel like they don't want to leave the care of their oncologist who's been taking care of them for this whole cancer journey that they have and sort of transition to this other team that can help them. What do you think about how the role oncologists can play in sort of coordinating with hospice or still being a part of the patient's care after they've entered hospice care? Because a lot of, when we look at quality measurement, we look at kind of how long someone is in hospice care as a measure of good quality, and the average being pretty short, about a week, and looking at can we get patients into hospice care earlier so they have that support that they need to plan for the good death. But then that does require that sort of transition. But then there's still that connection back to oncology. So what do you think about that?
And that's again very good point that you bring up, Shelley. The patients frequently know that they're ready for death, but they think that by bringing up issue about going to hospice care is failing their own coach. And I want to share another example of my patient. She was, I think, about almost 81-year-old. She had multiple recurrences of ovarian cancer. And I could see that she was failing, but her family was all over the country. One son was in Vegas, the other son was at Myrtle Beach. So I requested her that, if you could get all of them together, it would be nice. So she brings all of them together. And then I sat in a conference room and started telling her that, we've done so many things and it looks like I can keep trying. And I said, I'm a businessman. I make money by treating you, but I think the time has come that we need to shift our gears. And she kind of had a startling feeling. And I said, what do you mean? I said, and I think, have you thought of comfort care? She said, please go on. I said, would you like me to discuss about hospice care? Hallelujah. She just jumped up. She said, I did not want to bring it up because I did not want to fail you. So frequently, patients don't bring it up, not because they don't think it's necessary. I think it's because they do not want to fail me as an oncologist. And you rightly said that as a coach, as a leader of the team that's continuing this struggle, patients feel morally obliged not to bring it up. And so far, in my experience, Shelley, outside of one or two events where patients had specific requests that didn't want to go for hospice, virtually every patient said, I was waiting for you to bring it up, Dr. Patel, because I feel that if I brought it up, I think I'm failing you and I don't want to fail you. So, and not just that, anytime I talk about hospice care, not a single, I said, if you want a second opinion, I can coordinate that for you to go to Duke or Wake Forest or I said, no, Doc, we have full faith in you. If you say that we are ready, I'm ready for it. So onus falls on oncologist as a captain of the team to identify when the time is up and when we should be shifting gears to hospice care. But you're right. In the US, only 42% patients die in hospice care. That means 58% don't die in hospice care. And second thing is in Medicare parameters, 3 days hospice stay is acceptable. I think it should be at least 3 to 6 months because it allows people time to come to terms. We all know that nobody who came into this physical body is going to live forever. But if we prepare them, if we get them ready, I think we can be doing a lot better service to the society as a whole.
Yeah, and I think about my father-in-law, he was in hospice care for 2 years. And it
Hmm.
wasn't a mistake that when he entered hospice care, it was, I know that the definition is that you're reasonably expected to live 6 months or less, and that was accurate. But the fact that he got the care he needed to have a decent quality of life, and he actually did better and lived well for much of that and continued living with hospice care. And it was fairly minimal hospice care at first, but then the intensity increased as his needs increased, but he lived for 2 years with it. And then I think about my dear friend who died at age 43 of cancer, and he was a doctor himself, an internal medicine doctor. And in his case, he's the one who brought it up to his oncologist. I think it's time for hospice care. And his oncologist is the one who really, he said, well, I think I've never had a patient throw in the towel after one line of therapy. And in doing that, really kind of, my friend had done kind of the effort he needed to do to get his partner and his family on board with the fact that this might be nearing the end. And with that one sort of casual statement that his oncologist made, kind of threw everything up in the air, and they started thinking about maybe there are options. They started researching other treatments, and the next day he was able to have a CT scan that had been delayed because he couldn't keep the fluids down, and showed the cancer was rampant. He went home with hospice care and died a week later. And I just feel like he should have had, like you said, longer. He should have had more hospice care. He should have been in hospice care longer, because it would have helped him manage the really terrible side effects he was dealing with and have a better quality of life. But one of the things that struck me, you talked about the need for physicians to rise above their own hopes, fears, and vulnerabilities, to be candid in preparing patients. And I thought of my friend because I do think, partially because he was a doctor himself and similar age to his oncologist, that maybe there was a sort of identification there, and this fear of not being able to acknowledge that this person who was like him in a lot of ways was dying. And I wonder how much the oncologist's fears and hopes do play into how they have these difficult discussions with patients about dying.
This is excellent point again, Shirley. I think every point that you bring up are very, very relevant to the end of life care. I just recently, we had a colleague who's about 4 years older than me. He's an oncologist. He was an oncologist himself, was diagnosed with the brain tumor, and he chose to say, I'm done. I don't want to do anything. He passed away in 3 months. So he was quite aware of what he was up against. And there was a very interesting article. I don't remember, was it at New York Times or Wall Street Journal, but it said that why doctors die differently than the patients. And then you bring up the same topic, that we need to educate our physicians to the fact that by going to hospice is not losing the battle. I still come back to the same topic, that first of all, our system is not prepared to teach doctors how to bring communications on the end of life care. Second thing is, during the residency or fellowship, death is seen more as a stigmatizing the failure rather than kind of, an experience that could be shared with everybody else. And the third thing is that, again, deciding the winners and losers in this war makes people feel uncomfortable saying that, am I not smart enough to offer different kind of option? And then I think it has to go back to the training of the physicians, as well as probably more and more structured programs that could help break the ice about the end of life care, and that it's the right way to help people to leave this world. And coming back to what you said about interesting point about your father-in-law, there have been small studies, it's not very large studies, that have shown that in certain conditions, for example, in pancreatic cancer patient, if they were placed on the palliative or hospice care, they lived a little longer. It's not because you did any magic, but if a patient who's undergoing active chemotherapy, third or fourth line, say for pancreatic or lung cancer, they have more likelihood of being hospitalized for complication. And hospitalization itself is a risk factor for death, because you take a walking patient who actually stops doing everything, gets into ICU with stage 4 cancer, they have a high risk of developing blood clots. They have a high risk of developing the hospital-acquired nosocomial pneumonia. So there is a risk of kind of, hospital or healthcare associated condition itself that can accelerate the process of death in this vulnerable population. So hospice care at home or at appropriate location not only adds quality, but also in some situation, it's been shown to improve maybe a week or two, a little longer survival in patients in certain situations.
And it seems to me too that there's just this tension between the science, because oncology, obviously, it's a scientific field. It's a very technical field. You're looking at, you have to know about many different types of cancers, about keep up with the science of all the new treatments. But then also there's just that humanity side of, talking to patients and helping them make these difficult decisions. And you need both as an oncologist. And we have, if you have a palliative care specialist who you can help with engaging on discussions about, advanced care planning or things like that, that's great, but not everybody has that. And so, how do we teach oncologists, I guess, to have these discussions at the same time, that they sort of have to blend the science and the humanity?
And I think, it looked like you're reading my mind, all these discussions, because I always equate my practice philosophy, how I'm different compared to my colleagues, is that we take a reductionist approach in oncology. We reduce the human being down to the piece of tissue. So when we talk about patients, she's a breast cancer patient with liver mets. No, she's Anna. She's 48-year-old. She's got a family. So we have to bring humanization of cancer treatment. And I kind of, give famous example of the lion's eye view, which is more like a predatorial, where we look at life as a predator and a prey, where I look at cancer as a prey and I'm more like a predator. But I would rather take an eagle's eye view, which allows me to lift up off the ground, look at the whole panorama, so I can then look at Anna's husband, Anna's sister, Anna's daughter, Anna's kids. So when I take that concept of not the reductionist, but the macro cosmic view of life, I can understand what would be impacted if Anna goes through the 1, 2, 3, 4, 5. So I become the part of the Anna's ecosystem, where I go with her to a place in spirits. I realize that, if Anna had to spend, say, 6 days out of her last 6 months in the hospital ER, that denies her time to take away from her family members. So taking eagle's eye view from 30,000 feet view, working with Anna, allows me to target tumor when I have to, when, how an eagle can come down with telescopic vision to grab a snake. But then rest of the time, eagle continues to look at the world panorama and understand why things happen and why should they be happening. So taking the humanistic, humanizing view and not the reductionist, tumor-directed view is what would allow us to keep the husband, wife, father, son, uncle, aunt, sister, mother in the focus.
Yeah, that's so important, because and we hear that from patients all the time, that they want this holistic approach that looks at them as a person living with cancer, not as a tumor type or a disease. And one advocate that I think is so wise said to me that we have to match the treatment with the life, not just the tumor type, but the person's life.
Right, so, exactly.
So one last question I have for you. As an oncologist, you have to face losing patients and facing death so regularly. How do you personally cope with it? Because it must be a huge burden on oncologists to invest so much, time and care of patients that you end up losing. So how do you cope with that?
So I don't see death as an end to relationship, in my opinion. I think we are indestructible, eternal, infinite, omniscient existence. I'm still in that quest to define what we would be once the physical mortal remains go away. But I look at, in my book chapter, there's a chapter in the epilogue, which is the fourth dimension of life, where I've equated that, we are the entangled DNA elements floating freely in this space. If you look into before I was born, when I was conceptualized, when I was conceived in my mother's womb, I was a 4-micron cell with DNA information that was going to define this 2-meter square body that's talking to you right now. So when I leave this 2-meter square body, what will happen is the genetic code that was part of the conceived DNA 60 years back goes into the environment in ethereal space as a 2 entangled carbon, phosphorus, nitrogen, oxygen, hydrogen elements in double-stranded DNA. And the physical mortal remain go back to the earth. Or I've decided to give over my body to med school, so somebody will cut open the body and find out, how the heart functions. If you look into COVID-19 has taught me the analogy that I use frequently. So COVID-19 is a 12 base pair long RNA fragment. When it enters my body, it picks up a cell, and my cell has about 3 billion base pair long DNA element. So the COVID-19 opens up the DNA, makes about 100 billion copies out of one cell, and then wraps around my own body's element into making the copies of its own prodigy. So if my elements can be converted into the COVID-19, which again travels freely into the space, maybe when I die, my DNA element will be floating in the space and finding its new home. And genetic code is universal, Shally. So I have a second book contract that I'm working on with the Penguin Random House on the soul genome, where I want to kind of somehow or the other equate that we don't die when we die. We just continue in different ethereal form, like almost like Einstein says, this energy cannot be destroyed. It can metamorphose itself in different forms.
So thank you so much, Dr. Patel, for spending time with us today and talking about your book. It's really wonderful, and I appreciate how much care and attention and how much you give to your patients. Clearly, I think they're lucky to have you, and I really appreciate you spending time with us today. Thank you.
And I feel honored to work with you. I think we'll be working a lot more because I'm going to take over as a president next year. So for 2 years, I'll be seeing you back and forth in DC.
Great. Wonderful. Thank you so much. I hope you have a wonderful day.
You too, ma'am. Thank you very much. Bye-bye.